to AACR. We sorry we missed you. Please come next time. Please increase membership through your contacts. Go to the website and see what's happening at SFPM. That's the introduction. Next, I'd like to introduce Carla Grandori, CEO of SEngine Precision Medicine, and also founder of Cure First, a nonprofit. And take it away, Carla. Sorry about that little hiccup, but we're smooth sailing from now on. Take it away.
Thanks. Really excited to talk to the SFPM, and it's been a while. And first, not that I want to preach to the choir. Next slide. The next two slides are going to have the a reference to the Genie project, in case you haven't come across that study. But the senior author is a SEngine co-founder and director of bioinformatics, Brady Bernard. And so he, through this analysis, they arrived to a precise estimate of the cancer types that can be informed by genomics. Next slide. Which is only 17%. And this is based on tumors that harbor level 1 and 2 alterations corresponding to FDA-approved standard of care biomarkers. So even in cases where there are biomarkers that correspond to drugs not approved, still there is a need of a functional confirmation. And so I will show some data on how functional assessment can help on this instance. So we have a lot to do for 83% of tumors. And what's special about this study is that examined tumors that were recurrent and pre-treated, different from TCGA. Next slide. So you might be familiar with the Paris test and similar approaches. This is just a schematic overview of how we derive patient-derived organoids. Depending though on the tumor types, there might be involvement of matrigel, no matrigel, and for certain tumor type 2Ds, especially for certain sarcomas. So we and we receive samples from surgical resection, core needle biopsies, or body fluids. We test them through high throughput methods, and I'll have a little more detail in the next slide, provide a report, and obviously then the physician and often a tumor board. Great, yeah. The next slide shows that we have a clear certification and hundreds of standard operating procedures that cover all these processes from the sample acquisition and patient intake. And since the beginning of SEngine in 2016, we have asked patients to optionally consent to our internal IRB protocol to be able to utilize the data for research. So then there is, and we have a clinical coordinator in this first step. Then specimen process is by the organoid team. We do sequence all organoid by whole exome sequencing simply for tumor confirmation. And then the next steps involves designing a customized test that usually comprises of 47 drugs per patient. The cells are plated. The drugs are delivered through the echoacoustic droplet ejection system. And then the screens are read. We use cell titer glow. And the data are processed through a series of analytics. And then we are able to generate report in an automated fashion, which are reviewed by 2 PhDs. Next slide. So this is illustrated drug library that covers about 68 targets, many targets and multiple options. And again, I want to point out that this is one of the rate limiting steps of being successful. The number of targets, the drugs, is still very limited. And I believe that if we need to make progress, especially when we start with recurrent patients that are heavily pretreated, chemotherapies at that point, either the patient is not able to tolerate or they are ineffective, as we are have found out. So we need more targeted therapies, but we are working with what we have with the current menu. Next slide. So again, our library is skewed toward FDA-approved drugs, but we also include phase 1, phase 2, phase 3 in case patients can access the drug through clinical trials. Next slide. So here what we are today, we have accrued about 1,020 samples. The majority, at the beginning, the first 300 or so samples were research samples. And again, in this, we have done collaborative studies with several groups, Australia, Europe, and others, and not all the samples we have had the permission to include in our testing. But this gives you a broad overview of the cancer types. I apologize for the colors, but they may wake us up this morning. Large percentage are ovarian. We have a strong collaborations about many years with the University of Washington, and just alone them have sent over 100 samples. But we also have, breast, colorectal, pancreas, and many rare tumors. We accept any tumor types. And so that has led us to experience with many different tissues. Now, the success rate is really highly dependent on how the samples is transported and the amount of sample. I think we just heard pathologies commenting that often biopsies have no tumor cells. So our failure rate, the majority of failure rate, is due to the lack of tumor cells detectable at the beginning when we receive the sample. But when, again, they meet all criteria, we have a high success rate. Next slide, please. This is from a poster that was presented at the ACR this year from Rachele Rosati, who's our director of organoids since the inception of SEngine. She's been really responsible for optimizing the procedures. And so the conclusions here are pretty striking, that over 90% of samples, and here are these various examples of cancer types, functional testing can identify one or more drugs that have an exceptional and good response in the Paris test. And this I've seen also shared by many of you, and the recent paper by Diana Zam on Nature Medicine confirms the high actionability of functional testing results. Of course, we need to prove that these the results that we obtain actually lead to improved outcome. So I wanted to add a word of caution. The word of caution is that I have heard many groups that may say, well, the test tells you this is the drug to use, let's use the top scoring drug. I think while we have observed clinical results with drugs that score exceptional to good, in vitro testing alone doesn't translate to drug responses in vivo with single agents, especially. And so it depends on the drug type and the disease type. And I want to emphasize, for example, low-grade serous ovarian cancer is a cancer type that it is responding also to single-agent drugs in our experience. But this, we believe, are exceptions. And that drug combinations are needed, and perhaps this is no news to you, but this can be complicated when a doctor has to obtain not just one off-label drugs, but two off-label drugs. So in any case, we must always interpret the results with clinical knowledge. For example, avoid agents that have failed as single agent, such as MEK inhibitors. And I'll show a slide. Next slide, please. So in one of our older observations was that often KRAS-driven tumor, this is an example from a colorectal cancer, And in red, you see a heat map showing that this tumor was basically tested with 120 agent, was basically resistant to the majority of drugs. Now, if we added a low dose of MEK inhibitor, we almost resensitize the tumor to a variety of agents, including EGFR inhibitors that notoriously are not, how would I say, demonstrate resistance in KRAS-driven colorectal cancer. Next slide. So the next slide will show you an actual example of how indeed functional testing shows that, first of all, let's look to the right, it confirms the negative correlation with EGFR inhibitors. KRAS mutant tumors have a low response to EGFR inhibitors on the right. However, the KRAS positive tumors, and these were tested before the availability of KRAS-directed therapy, MEK inhibitors are the highest scoring targeted drugs in the majority of G12 mutant KRAS tumors. And this was a pan-cancer analysis beyond colorectal. So next slide. So how did we use this information? We actually had a patient recently with locally advanced pancreatic cancer, 39 years old, inoperable. So the patient received 4 cycles of FOLFIRINOX with no response, and the graph should have been interrupted. So the FOLFIRINOX therapy arrives to the first data point. There was an interval. And then the patient entered a Paris concordant treatment, which was a combination of a MEK inhibitor, cobimetinib, and erlotinib. Now, both drugs for this particular patient did demonstrate sensitivity. And this drug combination was able to really normalize the CA 199. And it was really important to know that this patient had a good quality of life. Cobimetinib appears to be better tolerated than trametinib, for example, and is used on a 3 weeks on and off. And the patient actually reported that his pain went away while on the cobimetinib and erlotinib. So, of course, unfortunately, then there was progression. The patient started other treatments. We also added a 1-point venetoclax, and we actually did consult with Tony Litai, and the doctor of the patient consulted on the possibility to add this drug that also demonstrated sensitivity, but there was no, at that point, no response. So the patient went on to radiation therapy, and eventually we did a second test. Next slide, please. So interesting, the second test post-radiation still indicated MEK inhibitors and EGFR inhibitors as top scoring drugs. And again, I didn't mention, and I think I have a slide following this, that we use this scoring system from 15 to 1, with 15 being the highest score. And then we also divide them into categories of exceptional responses. And in this case, 15 and 14, we consider exceptional responses. So, however, the patient also showed this time, contrary to the first test, sensitivity to gemcitabine that can be part of the standard of care. And at this point, the doctor opted for gemcitabine and Abraxane for this patient, who led to a really decay of his conditions, while there was still a drop on the biomarker. The patient clinical condition deteriorated to the point that he was unable to receive further treatments. Next slide. So I'd like to now present this, again, a preliminary analysis, as we are waiting for more data on the real world overall survival. This is because we did notice through the years that there were many long-term survivors. So to give you a background, in the past 6 or 7 years, we consented 462 patients and across 103 different clinics. So you can imagine the difficulty. Number one challenge is receiving the follow-up. But for 84 patients we had, this the funnel that you see, we eliminated some patients, and at the end we had 84 patients that were evaluable for this analysis. And this was conducted by independent biostatisticians, which divided the group in group 1 was patients that received Paris Concordant treatments. And there is a caveat here. They must have received Paris Concordant treatment within 2 months from the anchor date, which was considered the Paris report date when the report was sent. Now, any patient that received treatment after the 2 months, even if it was Paris Concordant, were put in the control group, which otherwise contained patients that received standard of care drugs that were discordant or drug measured not measured by the test, such as immunotherapy. Any questions about these two groups of patients? So we can move on to the next slide.
I'm sorry, I am not an oncologist. I wanted to ask, like, why did you put the patients who received this Paris treatment, Concord treatment 2 months after the anchor date? I don't understand that part. Sorry.
Yes, no, I don't understand either, but the reason is because if the patient had the treatment, let's say this was explained to us by the biostatisticians, and was that they might have had in between some other treatment that could have they could have influenced the response. And because if we use the actual treatment start date, then we wouldn't have for the control group an equivalent date. So these are really, I feel like, semantic, and this is why this is preliminary, and we are going to next examine 3 months and other months and see how the results different. But I have to say that for eventually, hopefully we can include these patients. Let's put it that way. Next slide. So I wanted to give you an idea of the cohort. Amazingly enough, without, obviously not intentionally, because this was just happened, which patient could access Paris guided treatment and patient that didn't, we had a pretty equilibrated cohort. For example, while the age of diagnosis was 48 on average for the Paris guided, and the control was 53, so there was a little bit of difference, but the time at and the age of sample collection was pretty similar, as we can see here, both in range and average. The gender also was mostly females. It is because we have an abundance of ovarian and breast cancers. Cancer types are very similar. You can look at the graph on the side, but the statistic, the actual statistics also reflect that. Most patients were at late stages, stage 4 and 3. 4, let's say, the majority, and very few patients that were treatment naive. And the lines of previous treatment also were pretty similar among these different groups. Next slide. The ECOG score, we didn't have for all patients, but the patients that we had the ECOG score, they were also similar between the two groups. So, and this is important to pause. So the ECOG score was actually good, 0 to 1 for the majority of patients. So this is, I think, important to keep in mind that patients that will seek the Paris test or functional testing are patients that are, in good conditions. Next slide. So these are the results of the median survival. There is 15 months for groups that received Paris concordant treatment, and group 2, only 5.8 months. Now, the hazard ratio calculation based on the statistical analysis indicated also a survival advantage, but didn't meet statistical significance. And therefore, we are now increasing our cohort simply because the number were small numbers still. But I'd like to conclude this section with, next slide, please. With looking at the data as a scientist, as myself will look at. And so I just want to look at every patient. And by the way, I have looked at the history of every single patient in this cohort because we are extracting predictive values and others. And I was really surprised by patients that we had tested way back in 2016, and they're still alive. So if you look at this, we have, and we put a threshold at over 10 months. There are 23 patients in group 1, Paris concordant group, and 12 patients in the other group. And over 20 months, it's also 12 patients and 4. And so there is a substantial difference, again, in the, if you want, the number of exceptionally long-lived patients. And you might think that this corresponds to a group of exceptional responders, even if, doesn't, the overall statistical analysis done in this particular way didn't show statistical significance. Next slide. So I wanted to point out to a book that I don't know how many of you have read this book, Living Medicine by Fred Applebaum. Anyone in the audience? Nobody. Okay, so Fred Applebaum was the former CMO of the Fred Hutchinson Cancer Center that describes, this is beautifully written book that describes the history of bone marrow transplant. And when I read this particular portion of the, of the book, page 140, there was a review that concluded in a summary that bone marrow transplantation is questionably worth for patients with end-stage AML. And in the rebuttal of the same issues, Don Thomas, who received the Nobel Prize for starting bone marrow transplant, replied, "The Seattle marrow transplant team and these 5 patients, referring to the long-term survivors, do not agree with the statement that marrow transplantation is of questionable worth." And so I want to remember this history. It took decades to arrive to go from 3%, to a large percent of patients that are actually cured of a disease that was incurable. So I think I feel we have a lot of hope that functional testing will improve survival of cancer patients. Next slide. So I want to tell you some of the example of these long survivals, and some are published. Next slide. So this is a very first case. It's not even included in our cohort because it was part of a clinical trial of head and neck cancer with a WEE1 inhibitor that was derived from some of our functional studies prior to SEngine. We can see that there were exceptional responders, such as this one shown, where there was complete pathological responses, including the WEE1 inhibitor together with chemotherapy in treatment-naive patients. Next slide. The Paris test, at a time where we didn't have a score yet, but we had cells derived from the responder and the non-responder, demonstrated that actually we could detect the response to the WEE1 inhibitor in the patient that actually had a complete response, and vice versa in the non-responder patient. Next slide. This was one of the oldest cases of breast cancer. The patient is still alive now. As we know, the last, as we know, it was of 2023 that we last checked, and the patient is now on a different therapy. But it was the beginning for us to test drug combinations, and here they shows an area under the surface. We now use different metrics, but in any case, you could see that the combination of everolimus and tamoxifen, or olaparib and platinum, that is not shown here, indicated a response in a synergy score. So again, this patient obviously received a lot of other treatment in the course of her disease, but 2 of the treatment were Paris guided. Next slide. So here explaining sorry, a bit late, because we are getting into the showing a lot of scores. Again, the SPM score is from 15 to 1, and it comprises of both absolute metrics of response, such as area under the curve, but also comparative analysis. And this is essential for us to, especially in the grouping of various categories, which further groups the number into exceptional, good, moderate, low, and no response. Next slide. This is a case that's published in collaboration with an Australian group of oncologists that preserved organoids from their patients. And this patient, in my opinion, looking at the history, never really responds to FOLFIRI because recurrence were very, very, very frequent and with a short time post-treatment. And so, but only, and this is one of the patient excluded because the results of the Paris test was not utilized until a year later from the collection. At that point, however, the patient received gemcitabine, not normally used, and she had a demonstrated shrinkage of tumor by scan and 9 months overall survival. Next slide. This is a case of low-grade ovarian cancer that had an exceptional response, especially because the patient was in hospice care at the time of treatment. And you can see here both the organoids, the genomics. So one of the major mutation was a CHEK2 mutation. However, we did not detect a response to PARP inhibitors, for example, and none of the mutation really correlates directly with the response that we observed. So among the top scoring drugs was ibrutinib, a drug approved for lymphoma, that the patient was able to obtain because was a veteran. And next slide. Here, the time course of the patient receiving ibrutinib, received ibrutinib at the peak of the CA 125 was 320. The patient had a GI obstruction and was on an ECOG score of 3, unable to eat. And soon after ibrutinib, the CA 125 dropped to normal level and sustained for a number of months. And next slide, we'll have the follow-up from this patient. So after ibrutinib, we can see here about a year into ibrutinib, the CA 125 started to rise again. And so she pursued the second line of treatment, which was afatinib. Also, so ibrutinib and afatinib both target EGFR inhibitors, although there is the possibility that ibrutinib also targets BTK. We don't have mechanistic insights on these particular patients, but the fact that afatinib was able to control also the disease for a prolonged time, we suspect that EGFR pathways was what was targeted for this patient. Now, after afatinib, the patient progressed, and this is the patient started erlotinib and had benefit for a short period of time, but then passed away close to 3 years since the start of the Paris-guided treatments. Next slide. This is another long-term survivors of low-grade serous ovarian cancer that notoriously doesn't respond to chemotherapy. The response rate is about 4%. So this patient, who is very informed and savvy, has been one of our major spokesperson regarding the Paris test. And I perhaps some of you have seen videos on her on social media, but she received treatment after the Paris test with first line with lapatinib. Then most of it, again, we're compiling all the details for this case, is now published yet. Her disease biomarker was followed by liquid biopsies because her CA-125 was always not as high as for a high-grade serous. So once she started to progress on lapatinib, she then switched to the combination of the two top-scoring drugs, so added everolimus, the mTOR inhibitor. That was not easy to tolerate, so it was on and off, but was able to also keep the disease stable until she really couldn't tolerate everolimus anymore, and she, the doctor and the patient opted for local radiation. Following radiation, they resumed treatment, and currently the patient is on lapatinib, trametinib, and letrozole. Now, trametinib using at a quarter of the dose, and she's tolerating well because we've seen many patients not tolerating trametinib, and has had a normalization of, of her markers. And here below, I showed the comparison, the whole exome sequence comparison with the third party, showing again that there are no alteration of HER2, for example, to explain the lapatinib sensitivity. And but there is a KRAS mutation that is, I would say, an alternative allele, a Y166 to N. So a tyrosine to asparagine, and this is why part of the rationale that the doctor opted to include trametinib, which also scored in the Paris test. And the patient is a young patient in her 40s, and only recently agreed to add letrozole to her regimen. Next slide. So I wanted to give you an overview of low grade. So while we tested the majority are high grade serous because low grade is a rare tumor. What I find it really interesting is that if you look at this heat map and look at the dark blues clusters, you can see how different are the high grade serous. Let's look on the left side where the chemotherapies, are clustered, and we can see that high-grade serous do respond to platinum agent and responds to other chemotherapies and taxanes, for example. While in the low grade, as in the clinical setting is observed, there is a low % of patients that responds to those treatments. And there is instead a cluster of drugs and a cluster of patients that responds to these drugs, and these are mTOR inhibitor, EGFR inhibitor, HER2 inhibitor, and BTK inhibitors, and also somewhat to MEK inhibitors. And this has been observed already in relations with the potential RAS mutation in these patients. So I think the functional testing, if you wish, could classify tumors. And I think this it's very exciting. And at the bottom, you see clear cell and other tumor types that are, again, more different among each other than these two categories. Any questions on this before I move on the low grade, before I move on? And . Okay, maybe we'll save the questions for the end and comments. So I wanted to present a paper, a manuscript that we have in preparations for biliary tract cancer, which is also a major unmet need, even if a rare cancer, because there is only two treatments actually, which is gem-cis as chemotherapies, and for patients that have FGFR translocations, FGFR inhibitor are now FDA approved. So we use both, again, surgical resection and core needle biopsies, and generally speaking, the most successful are surgical resections in terms of deriving organoids. And again, the overall success rate is high if the sample is good at the beginning. So that is always the case on what we observed. Again, here there is an analysis of different anatomical sites and the different type of biliary tract cancers. Next slide. So here I want to ask you a question now that you might have seen and are familiar with this heat map. Which side is the left side, panel A and panel B? Where would you think that chemotherapy panels are, on the left or on the right, A or B? Any volunteer? There is no penalty if you guess wrong. Chris. I wish probably I can't remove now.
Somebody says panel B. Someone also says panel B. We have two panel B votes.
Okay, so
yep.
Because it is a PDF, we can't remove it, but please believe me, the left side group A are chemotherapies. The only chemotherapies that do have a signal are actually are cisplatinum and gemcitabine. So very poor response to chemotherapies, while there is a huge opportunity in the targeted therapies. And apologies that these are blinded. Again, I will send the proper PowerPoint, but what we can see here on the B panel, the cluster, here are MEK inhibitors, EGFR inhibitors, and there is also a sensitivity that we haven't seen in other solid tumors, which is a sensitivity to MDM2 inhibitors for these patients.
These tumors generally respond poorly to chemotherapy. That's, I think, was the point you were trying to make, which is reflected in the organoid assay.
Next slide, please. And this is an actual patient and the results of the Paris test. So this patient had a pathogenic translocation of FGFR2. It also had an FGFR2 amplification of P53 mutations and a number of variants of unknown significance, including in BRCA2. However, when we tested this organoids from this patient, the patient had already failed both FGFR-directed therapies and PARP inhibitor-directed therapies and chemotherapies. So however, the test indicated that dasatinib had an exceptional response, this BCR-ABL inhibitor and broad TKI. Interestingly, there is quite a literature around the potential of dasatinib in sensitivity in cholangiocarcinoma patients that have progressed also on FGFR inhibitors. And so this patient was able to receive dasatinib, and next slide. And had a good response. I will always remember the phone call from the husband that said that his wife enjoyed Christmas for the first time in years with dasatinib. The patient lived for 9 months, but again, it was very late stage and heavily pretreated patient. Next slide. So I will conclude a few examples of genomic concordance. I will go rather quickly because I would like to have time for questions. So next slide. So this is what we observe on a daily basis when we review reports. This is a patient of metastatic breast cancer, happens to have, again, dasatinib as top scoring drug, but concordant with genomic, the patient had a mutation in PIK3CA, pathogenic mutation, and indeed there were responses to, mTOR inhibitors, but importantly, tazelicib and alpelisib, two HER2 inhibitors. And also the patient was ER positive, and there was a response to afimoxifen. Next slide. We also could detect for this patient that there was no response to drug the patient took in the past. And this goes with our high concordance in the retrospective settings that we have also addressed in an aggregate analysis in ASCO 2021. And I don't know if I can get to that right now, but as an example. Next slide. Lung adenocarcinoma. The patient was positive for ALK-EML4 fusion, had been pre-treated with alectinib. They gave a score of 3, so it was not reported among the top targeted agent. But then lorlatinib, which is in fact the next in line treatment, had a good response, and that obviously helped the doctor select the next targeted agent. Next slide. This case is published, and it was a HER2 amplified pancreatic cancer with KRAS mutations. So in this case, we were surprised, if you wish, to see that in fact the top scoring drug was lapatinib, a HER2-directed therapy. And this prompted the therapy with trastuzumab. Next slide. The patient took trastuzumab with a stable disease for 9 months. Then she progressed and had both a personalized vaccine, radiotherapy, immunotherapy, so a number of treatments. But in addition, she also had a HER2 drug conjugates, which are very powerful. The patient has been disease-free since 2021. That, as we know, is that we last checked is on 2023. So this is a remarkable remission, and I encourage you to read the paper by King et al., and there is a reference. Next slide. I think I will skip the prospective and retrospective from ASCO that you will see in the PowerPoint that demonstrated in a limited case the good predictive value. And let's move to the conclusion slide. Okay, in summaries, I think that from what we are learning from many groups, including others, there is a strong predictive value of functional testing. And how we calculated the Paris test predictive value has been pan-cancer and pan-drugs. So I think, and it's very important to think about drugs that constitute the exception when we don't see a good concordance. And another time I will elaborate on those, but let's say we have a 71 prediction that includes mostly positive predictions in the prospective settings. The retrospective concordance is higher, is close to 80%, demonstrating, again, the value to demonstrate the resistance to drug the patient took in the past. We have a high genomic sensitivity to detect mutations, for example, HER2, PIK3CA, and we will have exact percentages. These are all in progress across at least hundreds of samples for each biomarker that is known. However, it's important to know that it's hard to calculate specificity because we do observe, as in the cases I showed you, responses to drugs that have biomarker. Well, they don't have the biomarker in the specific patients, yet the patient do respond to those drugs. Our real-world overall survival data suggests a survival advantage for patients who receive the Paris Concordant treatment. And I think, talking about the challenges, these are challenges that we are all facing. And I really hope that working together, we will be able to overcome these challenges and battles. So, and I thank the Society of Functional Precision Medicine for really playing a really crucial role in this endeavor. Thank you.
Great. Okay. Well, let's, if you'd like to just unmute yourself and ask your question, you can do that. Or there's a couple of in the chat box. So I'll give you a second for those people who just want to ask the question themselves to unmute themselves and ask.
I'll ask a quick question.
Yes.
Carla, that was beautiful. You guys have now, I think, one of the biggest series collected solid tumor results in this type of functional assay, which is great. I was just curious. I saw when you were presenting your results, and have you considered using the statistic of a PFS ratio, which others across both genomic and non-genomic precision medicine have found useful in quantifying the benefit from a guided therapy?
Yes, this what is now referred as the penultimate PFS. So comparison to the previous PFS of the patient. Yes, we are carrying that out. Yeah, that's very important.
And then I was also wondering, because you have such a large series, do you have some plans? I think it'd be very useful for you as well as the field as a whole to publish it. Sort of like a lot of this aggregation that you've shown us is impressive.
Yes, we are. Our entire team, we're only 12. So our entire team is dedicated to the Paris test. I'm the rate limiting step with carrying out. So that has been the rate limiting step. But now we have help of a group of biostatisticians, and also I want to remark that for 100+ patients from the University of Washington, they are carrying out the analysis and the data abstraction. So it should be finished this month. And then for colorectal, we also have a cohort with Cornell, and this is we are dependent on their data extractions, but the plan is to publish this year. Potentially, and this is, I like your advice, I like the idea of publishing the pan-cancer analysis, but I often hear they would be best to publish within different cohorts, ovarian or.
As a question,
decide yourself. I think since you're testing an overall approach, I think it's completely fine to look across many different tumors. I mean, look at the TRK people and TRK inhibitors. No one was questioning them for looking at multiple histologies, but you'll have to make your own decision.
Yeah. Thank you.
Thanks. Someone has asked, have you tried to go earlier in treatment with the Paris test? Earlier in the treatment course of the patient? As opposed to late stage.
I can remember, most of the patients were treated, at least one line of treatment. But I think and those patients, in fact, are the ones that do the best. We have started an analysis by the number of prior treatments.
Yeah.
Yeah.
I think we all agree that earlier treatment would be ideal, because then the patient has options later. Okay. How do you select the dose range? Does your scoring system vary depending on the dose range of each drug?
Yes. So we annotate the drug for the Cmax, and so the maximal observed serum dose, and we test the drug around that span. That's the best we can do, and really it's calibrating the response across all patients. It's what gives us the best reference ultimately. Yeah.
Okay. Let's see.
Chris, now you are actually upright instead of sideways. Be great.
Okay,
Okay.
that's great.
What's-
Great to know.
Yeah, great.
I guess someone asked, are you able to test drug combinations? Or that was or single agents? And I think you did talk about drug combination.
So here how now we're starting to incorporate matrices in drug combinations, but our typical method has been IC30. And so what we use, we do a first test, identify top scoring drug with the physician recommendation. We then use the choice drug at the IC30 and against all other drugs or a battery of drugs. And that's nice because it allows you to test a battery of drugs, but matrices are in course. And then
Right.
for the readout, CTG, yes, we use cell titer glow. And
Okay.
yes.
All right. Well, I think you deserve a medal for overcoming a rough start with your Zoom PowerPoint situation and presenting a wonderful seminar, very thought-provoking. And I really appreciate Carla's time here, and I also appreciate the SFPM for allowing this kind of work to proceed and bringing us all together towards a common goal. And I guess we'll see you in a month at our next SFPM monthly seminar. Anybody else have final comments?
Just it will be slightly less than a month. We had moved Carla's presentation because of the competition with ACR that we wanted to avoid. So it will be a little less than a month, but
Okay.
see you in May.
Yes.
All right. Adios, everyone. Thank you.
Thank you. Bye-bye.